Hello friends, uh, today I am going to deliberate on indications and initiation of mechanical ventilation with basic modes and terminologies involved into it. This was the talk which I delivered during Mahakritikon in the city of Nashik, Maharashtra in November 2023. So in another 30-35 minutes we will try to see how the mechanical ventilation works as far as basic modes are concerned, and how are we able to use the clinical terminologies in the clinical context related to mechanical ventilator. When you see a ventilator, it appears that it is complicated, but my friends, let me tell you, if we understand the subject in a proper way and try to apply the knowledge in a proper perspective, the ventilator is definitely not that complicated. Now, the simple rules as far as mechanical ventilation is concerned is the indication for intubation and mechanical ventilation is thinking about it. And remember, intubation is not an act of weakness. So, what are the aims and objectives of mechanical ventilation? Number one is, of course, removal of carbon dioxide and delivery of oxygen. It is to relieve the respiratory distress, especially to decrease the oxygen cost of breathing and reverse the respiratory muscle fatigue. It helps to improve the pulmonary gas exchange, thereby reversing the hypoxemia, the acute respiratory acidosis, and helping the pulmonary gas exchange. It also helps to alter the pressure volume relationships, predominantly to prevent or reverse atelectasis and to improve the lung compliance. It also helps to prevent the further lung injury. So this actually should be our aim, to also prevent the further lung injury. It has to work in such a way to avoid the complications and also to permit the lung and airway healing. So these are the few of the aims and objectives. What are we looking at when we put the patient on mechanical ventilation? Now, as far as indications are concerned, we put the patient on ventilator when the patient is not breathing, or when is he breathing but is not enough, especially in scenarios like hypoxemias and hypercapnias, where there is a refractory hypoxemia which implies the larger shunt. And here I want you to kind of get introduced to this formula of alveolar oxygen, which you could easily see here, which takes into account FiO2, the atmospheric pressure, the PaCO2, and the respiratory quotient. It is indicated in the patients who are breathing with normal gas exchange but with a high work of breathing, and of course for airway protection. At this point in time, I would like you all to get introduced to the types of respiratory failure. And remember, when we put the patient on ventilator, we definitely take help of arterial blood gas analysis to decide which type of respiratory failure is it, and also to have the initial setting on mechanical ventilator. As we know, type 1 is acute hypoxemic failure, type 2 is hypercapnic failure, type 3 is a post-operative failure, and type 4 is the patient with shock. Now, the positive pressure ventilation, what does it actually do is it has inflatory mechanism on the lung, which is actually similar to mouth artificial ventilation. there is a supraatmospheric pressure which is created at the upper airway, and the resultant pressure gradient between the upper airway and the lungs, which pushes the gas through the airway, and that is how the respiration actually gets initiated. And when all this done is in cyclical manner, this is called as IPPV, or intermittent positive pressure ventilation. Now let us make the things a little more easy. So the respiratory cycle starts with inspiration, and of course it ends with expiration. So between inspiration and expiration, when the inspiration ceases and the expiration starts, that is where the term cycle comes in, and it is a switch of inspiration to expiration, and this is the cycling, and we will come to that later. When the expiration gets initiated and when the inspiration starts, there is another terminology which we will again have a look at. So as I said, the cycling is the one where the inspiration ceases and expiration starts. In other words, there is a switching of inspiration to expiration, and this process is called as cycling of that particular ventilation. Trigger sensitivity is the one which initiates the inspiration. PEEP is nothing but positive and expiratory pressure, which is the pressure responsible for maintaining the alveoli and preventing them from collapsing. There are various modes when we talk of the mechanical ventilation, and we'll see to it, followed by the setting up of FiO2. So it's not very difficult to understand what does the cycling means, what does the trigger sensitivity means, and of course you must be aware of various modes, FiO2 and PEEP, and we will see. So setting up of your ventilator starts with tidal volume, the respiratory rate, the peak inspiratory flow, and the inspiratory time, the I ratio, which you all know, trigger sensitivity, PEEP, and FiO2. Now there are 4 types of cycling, or 4 types of cycled ventilators. So what is volume cycled? Is the one where inspiration ends when the preset tidal volume has been delivered. Pressure cycled is the one where inspiration ends when the preset inspiratory pressure has been reached. Time cycled is the one where inspiration ends when the preset inspiratory time has elapsed, and flow cycled is the one where inspiration ends when a preset inspiratory flow is reached. So you all are required to understand and remember these 4 types of various cycled modes, especially which will be helpful for exam going IDCCM and DRNB students. Now the PEEP is a positive pressure that will remain in the airways at the end of respiratory cycle or at the end of expiration, which is greater than the atmospheric pressure, and that is how it helps to inflate the alveoli and preventing them from collapsing. So PEEP also can be responsible for over distension, and it prevents the collapse. Triggering, as we saw, it could be of 3 types. The time trigger, which is a measure of period of time since last expiration. Flow trigger, where return flow is less than the delivered flow. And pressure triggered, where the drop in the baseline pressure. So we saw 4 types of cycling and 3 types of triggering. I ratio denotes the proportions of each breath cycle devoted to the inspiratory and expiratory phases, and the duration of each phase will depend on this ratio in conjunction with the overall respiratory rate. Now talking about the basic modes are the control modes, like controlled mandatory ventilation, assist control, whether it could be volume control or pressure control, and intermittent mandatory ventilation. The newer modes, as you could see on the right side, the PRVC, volume support, VAPS, APRV, or adaptive support ventilation or ASV. And winning modes, which you all probably know, is pressure support, CPAP, volume support, and SIV. So this is just a brief overview of what are the various modes the available modes are. Now again start with the basic understanding that remember this fluorescent green box or the rectangle as a spontaneous breathe and or a spontaneous mode where the rate and the power is decided by the patient. Also remember this red triangle for the controlled mode where the rate and the power is guided by the machine. So if you see henceforth, if you see a red triangle, it will be a controlled mode, and if you see a fluorescent rectangle, it is a spontaneous mode. And if you see a purple circle here, as you could see, it is nothing but a assist mode. So it is in between these two, and the rate is determined by the patient, whereas power is determined by the machine. So these are the simple things which you can remember. Now, as I told you, this is a spontaneous mode, this is assist mode because it is a purple circle, this is a control mode, this is a red triangle, and there is in between, you can see that there is a combination of the red triangle over the purple circle, and it is nothing but the assist control mode, which is the combination of both of the two, where minimum rate is given by the machine and additional rate is given by the patient, whereas power is provided by machine. So when you see a purple circle, on the top of that you see a red triangle, this is nothing but assist control mode. Now spontaneous breath looks something like this, where there is a graph which is flow against the time, and you could see that there is a pressure against time, and it looks something like this, and this is how a spontaneous breath looks like, and there is volume against time, and it looks something like this. So here again, if you have and if you remember, is the spontaneous, the assist mode, the assist control mode, and the control mode. So here there is a combination of a fluorescent rectangle with the red triangle. So this is nothing but intermittent mandatory ventilation, and this is a combination of spontaneous and the control mode. So you have a minimum rate and power for that rate is by the machine, whereas additional rate and the power for that rate is by the patient. And here if you can see, there is a combination of fluorescent green with purple circle along with a red triangle, which is nothing but SIMV, and the minimum rate and power for that rate is by the machine, whereas additional rate and the power for that rate is by the patient, but it is in a synchronized fashion. So that is how SIMV is different from IMV. And I hope if you remember these structures, and even if you are kind of just memorize those shapes, it will be very easy for you to know what mode you are dealing with. Now the control mode is a mode where every breath is fully supported, as the name suggests. It is time triggered. It can either be a volume or pressure targeted, and it guarantees a volume or pressure delivery depending on whether it is a pressure control mode or a volume control mode. So as you could see, it's a volume targeted ventilation. So here there is a flow versus time, and you could see that it is a square shaped waveform in a flow. This is the pressure tracing, pressure versus time, and as you could see, because it is a volume targeted, the pressure can be variable, and this is a volume versus time, and there is a preset tidal volume. So this is how the controlled mode, the volume targeted ventilation, can look like. So the assist control modes are the modes where every breath is fully supported. It can either be a pressure or the flow triggered, It can be a volume or pressure targeted, and it guarantees volume or pressure delivery with each breath. So as you could see that the same volume targeted ventilation, this is a flow versus time, this is pressure versus time, and this is volume versus time. You could see a small negative deflection here, which is nothing but the assist control volume control mode. Similarly, as you could see, this is a control mode where you cannot actually appreciate the negative deflection, so it becomes a control mode, and this becomes a assist control mode. As you can see here that these are the negative deflection, so this is a assist control, and the pressure tracing, which you could see that this can be variable, and here you can see that there is no negative deflection, so this is this is a control breath, whereas this is a backup breath. So in any patient whom you have put the patient on volume targeted assist control mode, you can see few breaths which are fully controlled without negative deflection, whereas you could see few breaths with negative deflection, and it is nothing but the assist control. As you could see, volume is static, or it is same because it is volume targeted ventilation. Similarly, the pressure targeted mode, where the pressure is limited, time is cycled, trigger is either time or pressure. You set the inspiratory time, you set the inspiratory pressure, it is flow variable and a decelerating flow pattern. As you could see here, this is a flow versus time graph or a scalar, where you could see that there is a decelerating flow here. This is a pressure versus time, and this is a set pressure, so you could see the uniform pressure tracing, and volume which is variable because the volume gets variable as it is a pressure targeted mode. The same assist control mode in pressure targeted ventilation, where you could see that there is a negative deflection, unlike this graph where there is no negative deflection. So the moment you see a decelerating flow and a negative deflection with a preset pressure, you are dealing with a assist control pressure control mode. Now what are the differences? As we could see, with pressure limited there is a guaranteed pressure, whereas in volume limited there is guaranteed tidal volume. In pressure limited there is variable tidal volume, whereas in volume limited there could be a variable pressure, which is very logical. In pressure limited there is a decelerating flow, whereas in volume limited there is a square waveform, and it is probably the commonest mode. So let us talk of pressure support mode. So this is a pressure targeted mode, and the patient triggered, since it is a support mode. There is a pressure sensor, it is flow cycled, and what is important is to remember that there is decrease in the flow to less than 25% of the peak flow when the inspiration ceases and the expiration starts. The patient is more comfortable in this mode, and we can monitor the minute volume and work of breathing in pressure support, and this is how it looks. As you could see, the decelerating pattern in the flow, where you can say that this is a pressure mode, and because it is a pressure support, the patient is triggering the breath. You can see that there is a variable kind of volumes, and you can see that this is how the pressure support scalar looks like. Now just a small quiz. So in the first set you can see that there is a pressure versus time, this is flow versus time, and this is volume versus time. So you can see that there is a square waveform and there is no negative deflection. So this mode, if you can see that this is a volume control where the volume is set and the pressure is variable. So the variable pressure with square waveform with set tidal volume, this has to be a volume control mode. Now this looks like same as this, but with this negative deflection So it's very easy to know that this is assist control, volume control. Okay. Now the third graph, you will see that there is a decelerating flow, and you can see that there is a set pressure here without a negative deflection and variable tidal volume. So this has to be a pressure control mode. Whereas in this particular graph you can see a negative deflection. All other things are same like the third one. So this is a assist control pressure control mode. And the last one, where you could see that there is a negative deflection, you can see that there is a decelerating flow, and you can see that there is a variable tidal volume. So this is nothing but a pressure support mode. So this is how you can identify by looking at the scalars as to which mode you are dealing with. How you need to set your alarms are, of course, the peak pressure alarm, the plateau pressure alarm, low pressure alarm, high respiratory rate alarm, and the tidal volume by minute ventilation alarm. So these are very important alarms which we need to set. And to start with, if you are choosing a mode, remember there is no mode which is superior to another. But in patients of ARDS, there have been huge data which has shown that the assist control mode and assist control volume control mode, which was extensively used, which improves the oxygenation, but it actually did not affect the mortality. SIMV is actually an inferior mode for weaning, and it has a doubtful role in muscle strength recovery. That is why in the present clinical context we may not use the SIMV mode as a weaning mode. So this is how you need to actually remember that there can be no mode superior to another. As far as tidal volume is concerned, the conventional tidal volume of 8 to 10 ml per kg, and in normal lungs especially, where you can use such volume. But in the patients of ARDS or obstructive airway disease, there is a concept of low tidal volume, where you may institute tidal volume ranging from 4 to 6 ml per kg. The only mode of ventilation which has shown mortality benefits was the application of assist control ventilation in patients of acute lung injury or ARDS, that is assist control volume control mode, to be very precise. And they actually utilized lower tidal volumes. The respiratory rate, I ratios, and the flow, it is to maintain the adequate minute ventilation. The high rates which are usually needed to compensate for low tidal volumes in patients of ARDS. The low rates which are needed to increase the expiratory time, especially in patients of obstructive airway diseases such as asthma and COPD. And the I ratio, which is normal, which is 1:2, and it has to be increased in the ratio of 1:4 in patients of COPDs or asthma to actually mitigate the problem of autopeep. And it can be inverse ratio ventilation in ARDS, which we keep sometimes even as 2:1. Flow which is constant or sometimes decelerating, as we saw in pressure control modes, sign or increase or decrease as per the need. And this we need to remember that these are another set of knobs which we need to set. The next is respiratory rate. The high respiratory rates which are used to compensate for low tidal volumes in the patients of ARDS, and the low rates to allow the full expiration, especially in the patients of obstructive airway. As far as FiO2 is concerned, initially it is 100%, and then it is gradually decreased to ensure adequate oxygenation for abnormal lungs. Bring it down to 60% as early as possible. The target PO2 may not be 100, 150, but it can be a low value as 60 also, where it corresponds to the saturation of 90%. We may not actually target the over oxygenation. And this is a demographic data where whites has a SpO2 of 92% and blacks 95%. For normal lungs, you can start with FiO2 of 50%, and FiO2 below 60% is not injurious to lungs, even if it is used for many days or weeks. So This is how you need to titrate FiO2 and have a target of getting it down to 60% or less than that as early as possible. As far as PEEP is concerned, as we know that normal lungs has a PEEP of 0 to 5, the triggered ventilation in obstructive airway disease equals to or about 75 to 80% less than to auto PEEP. So if there is a patient of the COPDs where there is a auto PEEP generated, where you can keep the PEEP a little more than the PEEP which is kept with the concept of the extrinsic PEEP which we put to take care of that intrinsic PEEP or auto PEEP. In bronchopleural fistulas, it is better to keep the lowest of PEEP, that is 0. In cardiogenic pulmonary edema, it can vary from 0 to 10. In ARDS, as per the ARDS net protocol, there is of course a strategy of high PEEP, and in literature, the PEEP can go as high as 24, but we usually don't put such a high PEEP. Before that, we have some other interventions in the form of prone position or ECMO which needs to be considered. So typically the initial settings for the patient with a normal lung mechanics could be a volume control mode, FiO2 of 50%, tidal volume ranging from 8 to 12 ml per kg and respiratory rate anywhere between 12 to 16 per minute. So just an exam, a small kind of quiz where, as we know that the normal lungs we just now discussed, in asthma we need to keep tidal volume a bit low, respiratory rate a bit low, because we want to have the washout of PCO2, flow of around 60. COPDs, again the same, but the flow can go up to about 80 liters per minute. In acute hypoxemic respiratory failure or ARDS, of course we have a FiO2 of 100%, low tidal volume strategy, high respiratory rate to compensate for the low tidal volume, and the PEEP which can go up as per the ARDS net protocol and flow of about 60. And in restrictive lung pathologies, essentially we can have the FiO2s lower than those of ARDS and a little lower rates and a flow of 60. So I think I will end up by this beautiful quote and a very inspirational quote which I myself happened to see this at the famous Burj Khalifa in Dubai, and it says the word impossible is not in the leaders' dictionaries. No matter how big the challenges, strong faith, determination, and resolve will overcome them. So I hope that all of you enjoyed and have some kind of understanding of the basic modes of mechanical ventilator, the initial setting of ventilator, and of course the various diseases where we encounter as intensivists, and what are the initial strategies of mechanical ventilator. Thank you very much.